This study and this proposal that, thank you for funding, is a continuation of a study that we've already initiated here at UC Irvine Health, looking at healthcare workers and testing for SARS-CoV-2 antibodies using a coronavirus antigen microarray, as well as conducting a survey to assess occupational and clinical risk factors, and then correlating those with the antibody results. And what this current grant will allow us to do is extend this study longitudinally and look at changes in the antibody prevalence over time. So, just to sort of orient everyone, you may remember when I presented to this committee the initial study, and now we've actually completed the initial study. So we've conducted 1,063 initial study visits with UCI healthcare workers. And each of those visits included a survey administration for the occupational clinical risk factors, as well as capillary blood collection via finger stick for testing on the coronavirus antigen microarray. This particular funding from Kraft COVID Committee will allow us to extend the study with a follow-up visit at 4 months, where we repeat survey and blood collection. And one of the advantages of studying this population for surveillance is that all of our healthcare workers undergo essentially daily symptom screening of every work day, walking into the hospital. And those of you who work in the hospital have probably experienced this. You have to type in your symptoms and screen. And if you screen positive for any symptoms, you undergo PCR testing for SARS-CoV-2. And so that's a really excellent population to assess for whether SARS-CoV-2 antibodies correlate with some level of clinical immunity, and which antibody we think the coronavirus antigen microarray is a good tool because it assesses a comprehensive antibody response that's both quantitative and looks at multiple antigens. So that we may be able to tell that certain antibody profiles to certain antigens are associated with some level of protection. The other area in which this funding will allow us to extend the study is to add a neutralizing antibody assay for the seropositives. And that is something that Hugh Davies is working on, getting all the BSL-3 approvals and obtaining live virus from BEI resources and getting that up and running. So, our study population was, we targeted 1,000 healthcare workers, and we included all comers who, work at UCI Health on the Orange campus who wanted to come to the study. We advertised widely. Actually, even before advertising, it seemed like by word of mouth, we got 500 people show up the first day. So it was really, within 2 weeks, we met our enrollment. So it was really much faster than any study I've ever been involved in. And Sebastian Schubel kind of led that effort, along with, we had some excellent medical student volunteers who were really, really crucial to getting this done. That it wouldn't have happened without them. So that was really excellent. And then we also have another part of the study where we are actually targeting some COVID units as well as some non-COVID units for a subset study, which is more of a case control design. And that one was in collaboration with Susan Huang and Shruti Gohil of Epidemiology Infection Prevention. So, and in that second subset study, we also looked at PCR positive and PCR negative healthcare workers who've already been tested as sort of a control. And it includes also another control with doing antibody testing using our diazyme assay in the clinical lab. But this funding focused on the finger stick part of the study, so I'm going to focus on that. So the REDCap survey included clinical risk factors, age, BMI, comorbidity, smoking, for instance, as well as occupational risk factors, role, unit, level of COVID contact, including how many days and procedures that have been performed on the COVID patients by the healthcare workers, as well as prior symptoms and prior testing and potentially prior treatment. And the capillary blood that is collected via finger stick using a lancet into a capillary tube for testing on microarray. And this is something that's much easier to get done than a phlebotomy test where the person has to show up for a blood draw. It's much less costly and much easier to enroll people. So, Phil Felgner and I sort of developed this coronavirus antigen microarray, and to do this looks at multiple different antigens, and this is kind of evolving. But for this study, there were 11 SARS-CoV-2 antigens on the array. And in order to define people as seroreactive or not, and we define high reactivity and low reactivity groups, we essentially took the optimal linear combination of those antigens that was able to discriminate positive controls, which are people who have PCR positive for COVID at least 7 days post-symptom onset, as well as negative controls, which were collected prior to the pandemic. And we get very excellent, our high reactivity threshold gives us a 98.9% specificity. And if we lower the threshold to increase our sensitivity, we can increase that to about 93% while maintaining a high specificity. So we define these high reactive and low reactive groups based on these thresholds. And now, again, this is evolving as well, but just to show you how the classification works, we take different antigens and the model assigns a coefficient to them and essentially calculates an optimal cutoff value based on the ROC curve in order to distinguish positive controls and negative controls. And so it's really a very dynamic, as we get more and more positive and negative controls, this algorithm continues to improve. So, subsequent iterations, we're able to get more and more accuracy. And this is just our initial data from a paper that's right now in revision with Nature Communications. But it's, clearly we look at the SARS-CoV-2 antigens, and this was an earlier version of the array with less antigens, but we see a clear differential between the PCR positives and the negative control. And we don't see much difference in other virus antigens. So that shows us that it's truly a SARS-CoV-2 specific signal that we're detecting. And so, we're in the process of analyzing all the data, but since this group did fund the study, I wanted to share a little bit of very preliminary results that, our reactivity rate is about 5% in the high reactive group and 2% in the low reactive group. And, this is one of the reasons why we wanted to extend the study is because, we think we actually have a good baseline data set here where 93% of our study was essentially non-reactive for SARS-CoV-2 antibodies. And by looking at it, and we see in the hospital, cases are spiking, in Orange County, we're going through a surge right now. And by doing a follow-up visit, we'll actually be able to capture dynamically the changes in antibodies, in the course of this surge. And we did find some, now because our seropositivity was low, the study was not powered to detect, very fine subgroup differences. And so, we did find some weak association with gender comorbidities, didn't really find association with the other clinical risk factors, age, BMI, smoking, or people, interestingly, people who reported symptoms, you may have heard from people, hey, I'm sure I got COVID. I had a cold in March. We didn't find that kind of report to be really statistically significantly associated with seropositivity. And we also, interestingly, COVID-19 patient contact didn't seem to be significantly associated with seropositivity, although among workers who did have patient contact, it seemed like there were higher levels of antibody in people who had more contact, either longer contact or procedures. But, again, the reason I present these is because our study initial visit was underpowered to detect many of these, but these are things that in a follow-up visit, we will really be able to pin down and really be able to, investigate and get good significance on some of these effects, see if they stand up. And so our next steps are just, we're doing data analysis reporting for this initial study visit. We're trying to write this up. I am in the process of submitting tomorrow an R21 grant proposal because, the funding from Craft COVID, we'll be able to do the 4-month follow-up. We actually want to do a 10-month follow-up as well. So I'm submitting an R21 for that. And with this additional funding, we can do the follow-up is at 4 months. And Hugh Davies has been working hard on optimizing the live virus neutralization assay platform with a lot of paperwork. But now finally, I think he's moving from the paperwork to the actual lab aspect, which is fun. So with that, I'll just stop there. And if anyone has any questions.
Okay, thanks. That was great. Really timely. We have about 3 minutes for questions. I'll start with one. So this relates, I guess, to the futures of this study. And that is, can you comment on the fact that people are beginning to discuss that these antibodies may be relatively short? There may be a spurt of antibody reactivity that then subsides in
Yeah.
SARS.
So there was a paper that came out in Nature Medicine, I believe Friday, that looked at that phenomenon. And the interesting thing with this paper, it was a low number of people. I think they looked at about 30 symptomatic and 30 asymptomatic people. And they found that they thought antibodies waned in some of these people within around 3 months. Now, that's a little odd for IgG. I mean, if you look at other coronaviruses, antibodies last an average of 1 to 2 years. IgG antibodies for generally other viruses tend to be longer lasting. So this is a bit interesting. It sort of is different from what we have found with other viruses. So I think it needs to be fleshed out a little bit further. But one thing is we can look at in our population, if let's say those 7% of people who had antibodies initially, we test them in follow-up and we don't see antibodies at 4 months, that indicates that maybe, what they found in the Chinese study was actually true. So it's something we'll be able to look at.
Yeah, so I think that's a very exciting aspect actually of your follow-up.
Yeah.
So here, there were several groups that have documented cross-reaction between SARS antibodies, so SARS-1 and SARS-2. And I wonder if what you're seeing there, the low reactivity that you're seeing in the second panel, this one right here, is really a peptide effect rather than a whole protein effect. So
I actually we do see cross-reactivity in our array, but our low reactive group is not that so much, because the antigens that we choose for the low reactive are not it includes the S2, but the model sort of is able to discriminate that, because with 90, basically in our negative controls, we see about 5 to 10% of cross-reactivity with specifically the S2 antigen, and a lower level cross-reactivity with the NP antigen. And so the model is able to sort of tease that out, and our low reactives are not necessarily just representing that, but that cross-reactivity is there. It is detectable by the array, and we can look into that further as we delve deeper into the data. We can look into whether those, particularly S2 and NP, kind of individual cross-reactivity with other coronaviruses is a factor that influences either immunity or potentially, likelihood of severe disease.
there is one specific antibody that was used by Ian Wilson and his group at Scripps to define an epitope on ACE2, on ACE2 that was recognized by both viruses, and they even measured binding constants. And they used one of the antibodies they used was from a SARS-1 patient. It may be that you don't have a SARS-1 patient accessible, and that's a possibility. But it would be nice to be able to compare a two-way cross on that.
Well, we actually see a lot of cross-reactivity, and particularly the NP antigen. I mean, if you look here, this rightmost bar is actually SARS-1 NP. So
that's what you'd expect, though.
Yeah.
That's an internal protein. Its structure is preserved because of its function. It's not preserved because of the, because it needs to be preserved, because it's protected. But S1, S2 is really important.
Yeah, no, so S2 tends to be more preserved. S1 tends to be a little more specific to SARS-2, yes.
Okay, thank you.